Good morning. As we say in Marathi, namaskar. As Dr. Banerjee said, this project has been about a year in the making. I was in Pune, India for 4 months about, and I did a program through the Alliance for Global Education at Ferguson College studying public health and development. And we had an option to do an internship or to do a directed research, and I chose to do a directed research in the villages outside of Pune. And I had some really wonderful professors and doctors actually that helped me put this project together and really carry it out. So it was a really, really incredible experience. This is a quote that I wanted to start out with. It's rather alarming, but unfortunately it speaks to a lot of truth in India. So I'll just read it. It says, "It is no coincidence that in the agricultural belts of North India, farmer families have started destroying male cattle over the past few decades. Once a valued asset, a bull has become redundant after the mechanization of agriculture. Other than stud duties, the bull is not worth using for any other productive work because tractors and other machines can do the job more efficiently and with greater comfort for the farmer. Therefore, a male calf is killed or sent to the butchery. There is no point in feeding the animal. The rationale is the same with the girl child." In India, it's reported that annually, in India, it is reported that nearly 700,000 girls are reported missing annually. The absence of a girl child is a result of illegal sex determination, neglect and family infanticide practiced in an effort to bear only male children. The preference for male children throughout many states in India has deep roots in the traditional and patriarchal context of Indian society. The responsibility of raising a daughter so that she can become an economic asset to her husband's family is extremely burdensome. Therefore, girl children tend to suffer greatly with their families during their development and throughout their adulthood. To give you some actual specific trends in gender, as you know, India is becoming a very great economic power in the world, but it's highly contrasted by some very unfortunate lack of development in gender equality. The first chart shows the national sex ratio trends from there are 3 surveys that have been conducted in India called National Family Health Surveys. Between 1987 and 1991, there were 941 girls per 1,000 boys. And then in the next survey, 93 to 97, there were 938, so it was falling. And then it fell drastically between 2000 and 2004 to 919 girls per 1,000 boys. It's actually now, this past December, the census has reported that it's hit the lowest average since Indian independence. It's now 914 girls per 1,000 boys. And in the state that I studied in, does anyone want to guess how low it is now? It's 883. And the state that I lived in is one of the most economically developed states. So to see that with development, the child sex ratio is falling is extremely alarming in India, and it's speaking to a lot of tradition that's holding on very strong even in the course of a lot of economic development and progress. The next chart speaks to women's desire to have children upon whether or not they have boys or girls, so it's speaking to child preference. In the first chart, if women had 2 boys and no girls, 96% of those women said, "I don't want to have any more children, I'm perfectly content." But if women had 2 girls and no boy children, about half of them said they would still have more children. And that's regardless of the fact of whether or not they could afford to have these children. It's a status, it's about honor, it's very cultural. So that's also an alarming thing, that fertility is working that way, that women strive to have children is whether or not they have a son. They feel. Where I lived is about in the center of the state a little bit. Just to give you a little background information about Maharashtra state, it's the second most populous state in India. It's home to 96,879 people. About 46,000 of them are women, 46,500. Overall, half of the population a little over half of the population does still live in rural areas, and agriculture is the primary means of income in the state, though Mumbai is located in the state, which is a huge center of information technology and economic development, as well as there are about 1,112 accounted villages in Maharashtra state. Another factor that is worth noting is that Maharashtra state actually about 40% of main roads in India go through this state. So trucking industry is a huge industry in Maharashtra state, which in public health terms is something to take note of because AIDS and HIV is the highest in Maharashtra because sex workers get the most work through the trucking industry. So in terms of women's health, men bringing these diseases back home to their villages, it's worth noting that. Okay, so this is the village that I was able to study. These are all photos from the village to give you kind of a visual snapshot. Kadus village is home to about 1,800 people. It's an agricultural village. They grow a lot of greens called menti and some rice and things like that, very limited sugar cane. I went with Vaishali, who was my translator. She was really, really excellent. She helped facilitate for myself and another female student from the University of Virginia in our studies. It's about 120 kilometers from Pune, so we took a bus, a public bus, a few times a week in about this time of year, so it's about 100 degrees at this time of the day. So it was an experience. People per month, the income is about 3,000 to 5,000 rupees per month, which is the equivalent per household, and that's about the equivalent of $67 to $112 per month, just to give you an idea. The village was in, it was within distance of government and private schools, but most of the children attended the government schools, which they did have from primary school through high school. And there was a government public healthcare center within about 4 kilometers and a private healthcare center within about 6 kilometers distance of the village. And in the case of this village, most of the people went to the private healthcare center, regardless of the fact that it was a little bit further. There's a lot of distrust in the government healthcare centers, except, which is interesting because there's no real regulation on the private sector of Indian health, but there is on the government sector. So unless you're a really good private sector healthcare physician, you don't really know the quality of health that you're getting. And it also is, there's an extended family structure, so that means that families with, a mother-in-law, parents, grandchildren, there are a lot of people living in one home. So the conditions of my investigation. This investigation was very interesting to construct because being new in India, I wanted to ask questions actually a lot about AIDS and HIV and sexually transmitted infections, but I didn't know the way to go about that in a way that was culturally appropriate. So there's a doctor named Dr. Leila Garda, who was a female physician who's done a lot of work in Pune district, and she helped me with developing a lot of the questions. We chose to have a female interpreter who was about the same caste as the women we'd be talking to for the comfort of these women, because caste and class is still a very influencing factor when it comes to accessing people. We also spoke with women in and around their homes. For their convenience, women work about 15 to 20 hours a day in and around their homes. So we wanted to be able to go to them so that it wasn't a burden for them to speak with us. And it was also to gain further cultural perspective for myself and the other students, since we are natives of the area. We also wanted to speak in what we call women's space, where the women would be, so that in the case that access to healthcare is an extremely sensitive topic for these women, and health is not really discussed between the genders. So we wanted to be able to speak with them in a space where they felt comfortable, where it was just women, and they could really, if they felt compelled, they could talk as much as they wanted to. And we tried to limit the presence of men in the area, but as you'll see, I didn't actually end up being able to finish a lot of my interviews because a man would be 20 feet away from us and women would just stop talking and they'd say, I don't know anything else. So that in itself was very telling. This is a graph showing child immunization between the age of 12 and 23 months. As you can see, Maharashtra is in the middle, it's the orange line, and then the national average of India is about 44% of kids are fully immunized, which full immunization in India in childhood is 6 vaccinations, which as India is a welfare state are paid for and provided for free for the government. The reason I chose to show this is that even though it says that about 58% of children have full immunizations in India, there have been a lot of speculation about girls being fully immunized because although there's a lot of cosmopolitan city and there's a lot of rural health missions, it's actually coming forth a lot of girls they're not getting the full immunizations that they need, and that's coming out because they're getting sick later, and also the death of girls between the ages of 1 and 4 is strikingly much higher than boys, which isn't natural because when infants are born, girls naturally have a predisposition to thrive more than boys. So the fact that girls are not thriving is extremely alarming, and that they're coming down with things like polio or different diseases that they should be having vaccinations for. So unfortunately, they are just kind of this is all just kind of coming to light with the International Institute of Population Science in India has been recording these excesses, but exact terms and numbers haven't been really clearly defined yet. So in terms of access to healthcare in rural Maharashtra, the 4 things that I focused on the most in my paper were gender disparities in health, urban and rural disparities among women, life expectancy and survival, education, wealth, and women's fertility. So urban and rural disparities, this is a little crazy looking, this graph, so I'll explain it. Education, residence, and weight. As you can see, the orange is showing that women are extremely thin, and the normal weight is in the middle, and then overweight to obese. The most important factor is in the middle where it says urban and rural. You can see that about twice as many women are extremely thin in rural areas as in urban areas. And that's extremely alarming because women in rural areas work about 15 to 20-hour days, starting with going to gather water at wells, working in their fields all day, providing lunch, and oftentimes while they are full-term pregnant if they are. So it's pretty important to note that these women don't have the strength to be carrying out the jobs that they're doing daily. So compared to urban, as I said, and that's about, very thin, it's about 100 pounds or less. So they're extremely thin. And the median weight is about 120 pounds, which by American standards is still pretty thin. And for doing the work that they're doing, in their case, it can be too. So it's a hard thing to measure. Food, nutrition, and knowledge of healthy diets is also seriously lacking, and poverty makes this problem of nutrition even worse. When the other girl that I was with was doing research on the way people prepared food, and she was realizing that a lot of times the way women were washing vegetables after they were cut up and things, they were actually throwing away a lot of the nutrients in the vegetables, and for having a limited diet, that's something that needs to be really considered, the way that women are preparing food. So life expectancy, health, and survival. Women actually have a higher life expectancy than men by about 3 to 4 years. I think it's about 67 years for a woman, about 63 to 64 for men. But their survival rate is incredibly low compared to men. It's about half between the ages of 15 and 19. And one of the factors in this is that women are incredibly anemic in India. It's been found that especially rural women have a lot of problems with anemia. And as you can see from this graph, about 33% of women have mild anemia, and only about 10% of men do. So when someone's eating in the house and someone's eating well, it's typically the male children or the men. And that's another problem, that 22% of children are anemic, but a majority of them are females. So that's another thing that, and we asked women in the villages, if you don't have a lot of food, who eats? Well, my son eats first, and then my daughter, and then me. So that was the way that it worked in the families. And then over here, this is institutional deliveries, which I thought was really a telling factor, because in Maharashtra there are even places where less than 50% of women have deliveries, institutional deliveries, which means that not necessarily they're going to a hospital, but just that they're going to a community health center to have their babies, or they're going to a public health center to have their babies. I was in the Pune area, which about 70 to 80% of women are having institutionalized deliveries, which is a good thing. But women reportedly mostly have their children at home, and within the same day are up cooking for their families, and within the next 2 days in their fields. And about 55% of breastfeeding women are anemic. So this is really alarming, and there's been a lot of initiative by the National Rural Health Mission to really bring women into these health facilities and monitor them for about 3 days, and also to give them both prenatal care and antenatal care after they have their children, to really check in with them and make sure that they're eating well, that they're getting the nutrition. And part of this, actually, they're so desperate to do this that they're paying women a stipend to come have their babies, stay for 3 days, get themselves weighed, get the babies weighed, make sure that they're producing breast milk well, and they're actually giving them clothes for their newborns. And there was a story that I found absolutely appalling. My public health professor was in a tribal area of Maharashtra, and his daughter went in the night after a woman had a baby. They were working at a public health care center, and the woman was gone. And she came back about 6 hours later. It was about 10 in the morning, or it was about 12 in the afternoon. She came back. She left around 6, and she came back with a newborn on her back. She walked 3 kilometers back to the healthcare center. And they said, "Where did you go? We told you to stay." And she said, "I told you I was going to stay. I came back. I'll stay tonight." And she didn't really, the concept of staying and resting and getting well and getting strong after having a baby doesn't really exist for these women. Their obligations are so strong to their families. So that was a really telling thing for me, and that's not really new news. That happens a lot. So determinations of access to healthcare, this is kind of a large chart, but these are called the hurdles of healthcare, and there are a lot of them: getting permission to go, getting money, distance to the healthcare facility, having to take transport, finding someone to go with you. And in the conditions of the village that I was in specifically, I wanted to focus on 4 of the main issues that women felt that I was able to kind of conclude from speaking with these women in their homes. 9 out of the 11 women I was able to survey claimed that they absolutely had to have a male family member go with them and help facilitate in the healthcare process. And those same 9 women all said that they don't have any money of their own, that the men in their family would have to pay for them to have any healthcare services. So any medication, any doctor's visits, all would have to be cared for and with a male family member, which already that brings a big problem to access because of the gap in communication between genders about healthcare. So if a woman is having problems, she's not going to go to a male family member most likely and say, you know, I feel like I'm having problems with my uterus. I feel like I'm sick, because there's a lot of stigma just about sickness in general. So those were 2 that were kind of combined with one another. The greatest barrier seemed to be the time that health centers that were accessible were actually open. In the area where I was studying, about even though the public health care center, the government one, was about 4 kilometers away, it was only open between the hours of 10 and 5. So most of these women, even if they wanted to go, there would be no time in their day for them to actually access this healthcare facility. And then another part that I wanted to focus on was whether or not there was a female health care provider. And the district level health survey reported that only about 30% of public health centers even have a female physician or clinician at those centers. So that is a very legitimate concern for these women. Is even if I go, will there be a woman for me to confide in? Will there be a woman for me to talk to about the problems that I'm having? So the survey questions that we constructed, were constructed, like I said, with the help of Dr. Leila Garda, who works at Allen Hospital in Pune. We constructed questions first regarding biographical information of each woman, their age, their education, the number of children they've had, to compile kind of the demographic of our survey. Women questioned were between ages of 18 and 55 in my survey, so there was kind of a broad spectrum. And these women were all women that were either married and had children, or in this extended family structure were kind of facilitating in a maternal capacity with children. Because for me, the main focus was, okay, how are these women perceiving their health care, and are they able to convey any knowledge about healthcare to their children? So we asked women to assess their own health as well. And it was very interesting because 9 of the women reported to be in good health, and I said, well, how do you measure your health? And they said, well, I eat 3 times a day, I eat well, I sleep well, and I'm able to complete all of my daily work, and I do it, and I'm strong. So, these were women in different households, and they said almost verbatim the same exact thing. So there was this notion of what it was to be well. And only 2 of the women said that they didn't really feel they were in great health, and I asked them why, and they complained of weakness, which I can only guess maybe had something to do with anemia and some other things. And they were also actually very thin, and one of them was 55, so there were different factors involved with that. The awareness of disease, which I'll focus on the next slide, including knowledge, perceptions, and associated stigmas with different disease. And then healthcare seeking behavior, if they go to private versus public healthcare centers, and in this survey, most of them went to private healthcare centers. How long it took to get there, the distance, and in most cases when I said I didn't see many cars, I saw mostly bullock carts, you know, they have really large cows that will carry them in their carts. And I said, well, how would you get there? And they said, well, there were about 2, our social worker actually was from the village. And he was one of the people that had a motorcycle. So if anyone needed something, they would send Ganesh out on a motorcycle, or they would have a rickshaw come and pick them up, or they would ride their bicycle, or just walk. And in that heat, to walk about 5 kilometers and being ill would be a pretty burdensome thing. And also about having a male facilitator. So the 5 diseases that I chose to focus on for this survey were sexually transmitted infections, HIV/AIDS, tuberculosis, malaria, and though it's not a disease, infertility, because it has a very high stigma in India that I wanted to really ask women about. So in terms of sexually transmitted infections, only 1 woman in my survey admitted to even knowing what a sexually transmitted infection was. She wouldn't give me any other information about how they were contracted or anything like that. And in Maharashtra, the district level health survey of 2008 reported that 24.5% of women overall did admit to being aware of sexually transmitted infections, so my data was rather skewed compared to that, but that's still an exceedingly low number of women, concerning, especially because there's a high incidence, especially in village areas, of pelvic inflammatory disease, which can be anything from inflammation of the fallopian tubes, of the uterus, really painful lower abdominal pain, things like that. And this is usually caused by the onset of chlamydia or gonorrhea in India, and that's really telling because a lot of these women are having symptoms of PID, and instead of going and trying to get it taken care of, they're just having hysterectomies. About half of the women in India above a certain age do have hysterectomies for fertility reasons, and in rural areas for reasons regarding these issues that they're having with their health. And the other alarming part of this is these hysterectomies aren't being performed by doctors. They're being performed by local barbers and people that are not any medically qualified at all to perform these surgeries. And some of it is in an effort because there's still a big barrier between women and their mother-in-laws in India, and sometimes women will ask, can I go, I feel ill, and their mother-in-laws will say, no, you're fine. And so their way of trying to solve the problem themselves and not really having the information about what they might be experiencing is to just go and have a hysterectomy, which is extremely invasive to do for these diseases which are curable for these women. And in terms of AIDS and HIV, 9 of the 11 women said that they had heard of HIV and AIDS, which was much higher than the statistic provided by the district level household survey of Maharashtra, which listed that only 64% of rural women had ever heard of AIDS and HIV. Only 5 responded regarding transmission and symptoms. They were all kind of a little squeamish to talk about it. Of those 5, only 2 provided comprehensive answers, including that HIV/AIDS is contracted through sexual contact or blood-to-blood transmission from mother to child. And then 2 of these women listed weight loss and immune system suppression as symptoms. And these 2 women actually had completed their first year of their bachelor's degree in the city and then had come home to be in their villages. So their access of this information was much higher than the other women. Between them, women's knowledge and awareness of handling disease, education and male preference, urban and rural disparities, and how they all come together to really form these unfortunate circumstances in which women really don't have the level of awareness that they should to be able to provide for themselves and for their families. So when I was conducting this research, this quote is what really compelled me to keep going with this research. Jawaharlal Nehru was the first Prime Minister of India and a very good friend of Mohandas Gandhi, said, "You can tell the condition of a nation by looking at the status of its women." And I felt that that was, especially for a man at this time, I thought that that was a really profound quote. And I felt really driven to, because when we were in India, we were being exposed to all these wonderful things that were happening, and I really wanted to investigate something that's kind of been slipped under the rug in a lot of ways, and that's women's health. And as they are such a huge facilitator for themselves and their families, I found this to be really compelling.